Amebiasis is an parasitic infection. Look at this picture, shows that amoeba in intestine. CT findings. MRI. Look at this amoebiatic liver abscess. Then ultrasound findings. Look at this liver abscess due to amoebiasis. A detail going on. Introduction. Amebiasis is a parasitic infection caused by Entamoeba histolytica, a protozoan that primarily affects the intestines. It is a significant health concern in developing countries with poor sanitation and is transmitted through contaminated food and water. A definition. Amebiasis is an intestinal illness caused by Entamoeba histolytica leading to dysentery, abdominal pain, and in severe cases, systemic complications such as liver abscess. Etymology. The term amoebiosis comes from the Greek word amoebi, meaning change or exchange, referring to the shape shifting nature of Entamoeba histolytica, the parasite that causes the disease. The suffix iosis is of Greek origin, commonly used in medical terminology to denote a disease or pathological condition. Types. 1. Intestinal amoebiasis. Infection remains confined to the intestine, causing diarrhea and dysentery. 2. Extraintestinal amoebiasis. The parasite spread to other organs, most commonly the liver, leading to abscess formation. 3. Asymptomatic carrier state. Individuals harbor the parasite but do not exhibit symptoms. Causes. 1. Ingestion of food or water contaminated with E. histolytica cyst. 2. Poor sanitation and hygiene. 3. Person to person contact via facial oral transmission. 4. Sexual contact, oral anal route. Risk factors. 1. Living in or traveling to endemic areas. 2. Poor hygiene and sanitation. 3. Immunosuppression, HIV/AIDS, malnutrition, corticosteroid use. 4. Institutional setting, nursing home, prisons. 5. Male to male sexual contact. Complications: 1. Severe dehydration due to prolonged diarrhea. 2. Amoebic liver abscess. 5. Perforation of the intestine leading to peritonitis. 4. Spread to other organs such as the lungs and brain. 5. Chronic colitis mimicking inflammatory bowel disease. Pathophysiology: ingestion of E. histolytica cysts via contaminated food or water. Excitation in the small intestine releasing trophozoitis. Colonization of the colon causing tissue inversion and ulceration. Production of cytotoxins leading to necrosis, dysentery and potential spread to the liver or other organs. Here is the step-by-step pathophysiology. 1. Ingestion of cyst. Infection begins when a person ingests E. histolytica cysts through contaminated food, water or hands. The cysts are resistant to gastric acid and pass through the stomach unharmed. 2. Excitation in the small intestine. In the small intestine, cysts undergo excitation releasing trophozoitis, active invasive forms. Each cyst release multiple trophozoitis which migrate to the colon. 3. Colonization in the large intestine. Trophozoitis adhere to the colonic mucosa using lectins and degrade mucus barriers. They multiply by binary fission and can remain as non-invasive colonizers or become pathogenic. 4. Inversion and tissue destruction when pathogenic histolytica, trophozoitis penetrate the intestinal mucosa using proteolytic enzyme. This leads to flask-shaped ulcers, necrosis, and inflammation. Trophocytis can involve blood vessels, leading to hematogenous spread. 5. Dissemination to extraintestinal sites. In severe cases, trophocytis enter the portal circulation and travel to the liver, causing amoebic liver abscess. Rarely they spread to the lungs and brain or other organs, leading to systemic complications. 6. Encystation and transmission. Some trophocytes transform back into cysts in the colon. These cysts are excreted in phases, completing the lifestyle and allowing transmission to new hosts. This stepwise process explains how E. histolytica causes both intestinal and extraintestinal disease in amebiasis. Signs and symptoms. 1. Mild to severe diarrhea. 2. Blood stools, dysentery. 3. Abdominal pain and cramping. 4. Nausea and vomiting. 5. Fever in severe cases. 6. Weight loss and fatigue. 7. Hepatomegaly in cases of liver abscess. Diagnosis. 1. Stool examination, microscopic identification of histolytica cysts or trophocytis. 2. Serological test, ELISA, PCR and antigen detection. 3. Colonoscopy for persistent cases with ulcers or inflammation. 4. Imaging, ultrasound, CT scan to detect liver abscess. Nursing diagnosis. 1. Diarrhea related to gastrointestinal infection. 2. Fluid volume deficit related to excessive fluid loss. 3. Risk for imbalanced nutrition due to malabsorption. 4. Hyperthermia related to systemic infection. 5. Risk for impaired skin integrity due to frequent diarrhea. Medical management. 1. Anti-parasitic therapy, metronidazole or tinidazole. followed by luminal agents such as aromomycin. 2. Fluid and electrolyte replacement, oral rehydration therapy ORT, or intravenous fluid for severe cases. 3. Pain management, analgesics for abdominal discomfort. 4. Antibiotics if secondary bacterial infection occurs. Nursing management. 1. Monitor hydration status and administer fluids. 2. Maintain strict and hygiene and sanitation practices. 3. Provide a dietary support, ensuring proper nutrition. 4. Educate the patient about hygiene, sanitation, and food safety. 5. Monitor for signs of complications such as dehydration or liver abscess. Treatment options. 1. Pharmacological, metronidazole, tinidazole, aromomycin. 2. Supportive therapy, IV fluids, pain relievers. 3. Surgical intervention, drainage of liver abscess if large or non-responsive to medication. Psychosocial medicine. 1. Patient education, importance of hygiene and safe food practices. 2. Emotional support, addressing anxiety and stress related to illness. 3. Community awareness programs, sanitation improvement initiatives. 4. Counseling, especially for patients with recurrent infections. 5. Support groups, encouraging discussions and sharing experiences. Prevention. 1. Boiling or treating drinking water. 2. Proper sanitation and disposal of human waste. 3. Hand washing with soap and water. 4. Avoiding raw or unwashed vegetables and fruits in endemic areas. 5. Safe sexual practices, especially in high risk groups. In conclusion, amebiasis remains a public health challenge, particularly in regions with inadequate sanitation. Early diagnosis and treatment are essential to prevent complications. Public health initiatives, including sanitation improvements and education, are crucial in reducing the disease burden worldwide. Thank you. Have a nice day.